Good morning, everyone. Welcome to the Woodrow Wilson Center. I want to thank you all for joining us this morning. My name is Jeff Tabelco. I have the good fortune of coordinating the Wilson Center's Global Health Initiative and directing our Environmental Change and Security Program. So with my colleague, Kayla Nostrowski, we are very pleased to host you here today for a discussion that we've entitled Expanding Access to Essential Maternal Health Commodities. This is the 9th meeting we've had in our maternal health series that we do in partnership and with the support of the Maternal Health Task Force. It's terrific that Tim Thomas can join us in person. We have some other folks, I think, online. UNFPA and also technical support from USAID. And so this has really been a collaborative group effort and one that I think has been very productive, trying to provide the forum and a space for discussion of these issues that unfortunately there aren't enough forum for doing it. So we're very pleased to see some new faces and some familiar faces who've engaged with us on these dialogues on critical issues. We're very, very fortunate to have Julia Bunting from DFID to chair and make some comments and help us through the day. Just a couple more housekeeping announcements before I introduce her is to say the next meeting in the series, Maternal Undernutrition Implementing Effective Solutions, is going to take place on December 15th. Same time, same place, so you can just put it in the calendar now, but you'll get the formal notice. And then also, as we have been able to do with the other meetings, we are webcasting this event live. The video will also be archived. What that means for us in the room is when it comes to the Q&A, if you could wait for one of my colleagues to bring you a microphone so the folks online can hear your question. For those of you who are watching online, two quick things. One, the PowerPoint presentations are in PDF form, and you can access them on the web page where you're clicking to get the video link. And if you'd like to submit a question, if you do it early in the hour, we'll try to get it into the discussion. Just ecsp@wilsoncenter.org. So I'm going to turn the floor over to Julia. Julia's been at DFID since 2000. She's currently the team leader of the AIDS and Reproductive Health team in the Policy and Research Directorate. She's led the UK government's effort to secure the new reproductive health target in MDGs, so working in that UN MDGs context as well. And in 2009, she became chair of the Reproductive Health Supplies Coalition, which is really setting the vision for what's become the recently launched Hand-to-Hand campaign to really bring family planning services and meet the unmet need for family planning services. So, Julia, I'm going to turn the floor over to you.
Great, thank you, Jeff, and welcome to everybody to this Expanding Access to Essential Maternal Health Commodities. Thank you to the Woodrow Wilson Center for hosting this, and to the Maternal Health Task Force and to UNFPA. This is a really important meeting and a really opportune time. And for those of you who know me through the Reproductive Health Supplies Coalition, which, as Jeff mentioned just now, I'm the chair of, you'll be aware, as I say very often, that I really think the stars are aligned at the moment for advancing this agenda. We've had a series of high-level commitments in 2010 trying to really advance MDG 5, both improving maternal health and improving access to reproductive health. And I think what we've seen coming out of the AU African Leaders Summit back in June, what we've seen coming out of the G8 Summit and the Canadian-led Muskoka Initiative for Women and Children's Health, and particularly what we've seen coming out of the UN Secretary-General's event in September and the high focus given to women and children's health and the global strategy, this really is a time now. We have 5 years to secure the MDG targets to meet those goals that the world community set in 2000. And I really believe that we've now got everything aligned in terms of the political momentum, in terms of potentially the financing, and we have a lot of the knowledge of what needs to be done. And I've said before in the Reproductive Health Supplies Coalition meetings that I think in some ways the difficult financial situation that the globe is facing at the moment is actually quite useful for some of the issues that we cover, because what you'll find is many donor agencies are really keen on results, on value for money, on getting best buy for their bucks. And what we know is that many of the commodities that we talk about in terms of reproductive and maternal health cost tiny, tiny amounts to deliver, but actually save lives and are some of the most cost-effective interventions we have, both in public health but in broader development. So I think we really now have the opportunity to make the case for why we should be advancing the reproductive and maternal health commodities. And I think we'll pick up on some of this in the discussion. As Jeff said, we've got two really great speakers here this morning who are going to give us some presentations, about 20-25 minutes each, that will give us some food for thought, and then we'll open up the discussion more broadly. And we're going to start with Elizabeth Madsen from Population International, who's a senior research associate there, who's going to talk to us broadly about some work that they've been doing on maternal health commodities. Thanks.
Great. Good morning, everyone. Thank you so much for being here, and thank you to Julia for the introduction, and special thanks to the Wilson Center and the Maternal Health Task Force and UNFPA for coordinating this excellent series. It's a pleasure to be part of it. I'd like to acknowledge my colleagues Jennifer Bergeson-Lockwood, now of USAID, and Jessica Bernstein of PAI, who are co-authors on the research that I'll be discussing today. As you may know, PAI, Population Action International, is new to the broader maternal health community. The focus of our mission has historically been primarily on family planning within the broader reproductive health field. The project that I'm discussing today builds on a decade of advocacy and research by many organizations around the world, including PAI, to increase the availability of reproductive health supplies. And when we say that in our community, we have typically meant contraceptives and condoms. My presentation will share the findings of some research that PAI conducted earlier this year as a scoping exercise to examine how some of the challenges and entry points that we've addressed in the reproductive health supplies community translate, or not, to supplies for safe pregnancy and delivery. I really look forward to a continuing dialogue in the discussion and in the weeks and months to come with all of the maternal health experts in this room about the next steps and opportunities for improving access to these particular commodities. And a quick note on terminology. You'll hear me use the word supplies most often, but it's interchangeable with the terms commodities and products. Whichever term we use, we take it to mean the medicines and equipment that improve health outcomes. In family planning, we often work under the powerful slogan, "No product, no program," coined by the supply chain experts at JSI. One question that arose quickly as we began this research is whether this mantra translates from family planning to maternal health supplies. Advocacy for maternal health supplies is in a bit of a nascent stage, and an evidence base contributes to understanding the size and scope of these challenges. Supplies are a key element in programs to improve maternal health, and they're also a tangible and visible hook to increase awareness and commitment. Policymakers whose eyes glaze over when they hear the term health system strengthening can grasp our ask much better when they learn that supply shelves in a clinic are bare, that women are making great efforts to reach facilities only to leave empty-handed. With the support of the Maternal Health Task Force and the Partnership for Maternal, Newborn, and Child Health, PAI undertook case study research earlier this year on the factors that inhibit universal access to maternal health supplies. We chose two countries, Bangladesh and Uganda, as examples. They're not meant to be compared against each other, but rather to provide examples of challenges and entry points in two contexts that are hopefully applicable to others. The research was conducted through interviews with over 40 key informants in each country. It wasn't a facility assessment, although we did visit multiple public and private sector facilities at fairly high levels of the health system in each country. And we looked not just at supply chain issues, but also the policy environment, the health system structure, financing, and the role of various donors and civil society organizations in terms of how each of these factors affect the availability of supplies. This research is intended to lay the groundwork for future advocacy and policy initiatives by providing an evidence base that's informed by local expertise. We hope that this information will help inform program implementation, funding decisions, and awareness raising. One of the first decisions that we had to make was which maternal health supplies to track. And we made this decision thanks to consultations with many maternal health experts, some of whom are in this room, and each of whom provided a wide range of suggestions. So we chose to track 4 specific commodities. Oxytocin, which is an injection used for the prevention and treatment of postpartum hemorrhage. Misoprostol, a tablet also used for the prevention and treatment of postpartum hemorrhage. Magnesium sulfate, an injection used for the treatment of preeclampsia and eclampsia. And manual vacuum aspirators, which are equipment used for early or incomplete abortion. Now, these are just a few of the wide array of supplies needed, but we selected them due to their impact on some of the most common direct causes of maternal mortality. In Africa, for example, postpartum hemorrhage causes 1/3 of all maternal deaths, and preeclampsia and eclampsia another 9%. Other supplies, like antibiotics, antiretrovirals, blood, expendables such as gloves, are also critically important and are also widely used for non-maternal indications. And of course, don't think that we're forgetting the family planning supplies that allow women and couples to prevent unintended pregnancies, which in turn are a major risk factor for maternal mortality and morbidity. Adding it up by the Guttmacher Institute and UNFPA has shown that meeting all unmet need for family planning would reduce the number of maternal deaths worldwide by 2/3. PAI's research on the barriers to universal access to contraceptives and condoms in 6 countries was published last year. So back to that question of whether the no product, no program slogan translates into maternal health supplies. Certainly, in this field, as in many others, without the product, there is no program. But maternal health is greatly shaped by broader health system strength or weakness. In family planning, provision of the supply, while not ideal unless combined with counseling and informed choice, goes a long way towards meeting a person's need for contraception. In maternal health, if the supply to prevent or treat a life-threatening complication is in stock, there must also be a way for a woman to reach it in time, sometimes a way for her to pay for it, and, in most cases, a provider who knows how to administer it. Shortages of supplies in maternal health are both a consequence of health system weaknesses, such as human resource shortages, and also a contributing factor to poor health outcomes, because a real or perceived shortage of supplies inhibits people from utilizing the health system. Uganda, for example, has a certain paradox in that 90% of pregnant women receive at least some antenatal care, but only 41% of women deliver in a facility, meaning that half of women make contact with the health system during their pregnancy but do not return to give birth. In Bangladesh, there's an extremely low rate of facility delivery to start with 85% of births occurring at the home. Now, in Uganda, nearly half of women say that they expect that supplies will not be available in facilities. And you can see the quote I included on this slide from a government official there, which demonstrates the importance of these products in motivating improved outcomes. In Uganda, only about half of hospitals, the highest level of the health system, in a 2007 assessment could provide the functions of basic emergency obstetric care, and only 8% of Health Centers 4, which is the highest level below hospitals. In Bangladesh, only 20% of Upazila Health Centers, also the highest level below hospitals, could provide emergency obstetric care. There are severe capacity challenges for both human resources and infrastructure. Uganda had a Ministry of Health report in late 2008 that showed that only half of staff positions across the health sector were filled, and about a third of midwife positions were unfilled. A few words on the financing of maternal health supplies. Unlike contraceptives and condoms, which still receive dedicated annual funding at the country level from donors, especially USAID and UNFPA, there's very little vertical programming for maternal health supplies, although of course there are many large and important donor projects that address programmatic issues like training or community engagement. Therefore, country governments have an important responsibility to cover the need for supplies through their own internally generated funds and from other donor sources, such as sector programming and budget-wide support. we found that maternal health supplies are often aggregated with other supplies in the reproductive health field within countries' budgets, and therefore very difficult to track exactly. Now, both of the countries that we studied do have budget lines that cover maternal health supplies together with other reproductive health supplies. But in both countries, these lines are regularly underspent against what is allocated. So in Uganda, for example, approximately $750,000 was allocated in the fiscal year that recently ended for reproductive health supplies. But as of early March, 9 months into that fiscal year, none of it had reportedly been spent. And even if these lines were fully spent, they wouldn't be sufficient. Uganda's government budget only covers 30% of essential medicine requirements, and more than 70% of health units are stocked out of at least one medicine each month. Also, Danida, the Danish aid agency, which has donated half of the health sector plan's credit line for medicines, is exiting the health sector entirely this year, leaving the question of whether the Ministry of Health and/or other donors will compensate. In Bangladesh, the unofficial costs for deliveries, normal deliveries, range from $11 to $22 in the public sector, in a country where the per capita annual income is less than $400. And these are costs for things like transportation, food, and under-the-table payments to staff. Women and their families there are regularly asked to purchase supplies when government facilities run short. The next 4 slides summarize some of the issues affecting availability of each of the 4 commodities that we followed. And of those 4 supplies, oxytocin, the injection used for the prevention and treatment of postpartum hemorrhage, is the most widely available in both countries, thanks in large part, I think, to adoption of the active management of the 3rd stage of labor system, which was widely supported by USAID and its partners. Bangladesh allows nearly all health workers to use oxytocin, including through the community level. But availability in facilities is lower than intended, with just more than half of district hospitals and an even smaller share of Upazila health centers maintaining it in stock in a study last year. Formal assessments show that oxytocin is more widely available in facilities in Uganda, but in the one health center 4 we visited in Kampala, there was only ergometrine, which is an alternative drug that is described by some providers as less effective. Uganda also has more restrictive regulations that limit the administration of oxytocin to higher cadres of health workers. Misoprostol was approved for postpartum hemorrhage in both countries in 2008. In Uganda, the approval followed an extensive period of debate due to concerns that the drug would be used for abortion, which is illegal in almost all cases. Providers in both countries reported favorably to us about misoprostol, saying that it's often preferable to oxytocin because the tablets are easier to administer and to consume than an injection. In both countries, community health workers, the most widespread level of the health system and the most critical in terms of outreach, are permitted to administer misoprostol, although there is some confusion about this in Bangladesh. Bangladesh also has pilot programs through NGOs in which misoprostol is distributed directly to pregnant women for their own use for the prevention of postpartum hemorrhage. Training on misoprostol has been slower and less widespread in Uganda. And both countries have received a donation from Venture Strategies Innovations for the initial supply of misoprostol, which is also available in Uganda through the NGO network PACE, which is affiliated with Population Services International. Both country governments plan to procure misoprostol with their own health budgets, but as of the time of our visits early this year, they had not done so. Magnesium sulfate, the injection used to treat preeclampsia and eclampsia, is the least widely available of the supplies that we studied, particularly in Uganda, despite government regulations that mandate it well below the district level. In Bangladesh, lower-level facilities are often able to provide the initial loading dose and then refer to a higher-level facility to complete the treatment. Still, availability of magnesium sulfate is low in Bangladesh, with less than half of hospitals and a quarter of Upazila health centers having it in stock. In Uganda, few providers are trained or actively using it, and respondents expressed uncertainty to us about whether midwives are allowed to distribute magnesium sulfate or only doctors. One government official there told us that providers are unaware that magnesium sulfate is available for ordering through the national medical stores, and some are using diazepam, an alternative drug that is less effective. MVAs, which are known in Bangladesh as MR kits, should also be available at fairly low levels of the health system. In Uganda, they're used to treat an incomplete abortion. In Bangladesh, they are also used for menstrual regulation up to 8 or 10 weeks following the last menstrual cycle, depending on the level of provider. Bangladesh allows a lower level of provider to administer MVAs than Uganda, but it's available only through certain facilities, and the consent of a husband or guardian is required. Shortages of MVAs are a current concern in Bangladesh. Facilities that rely on the government for their MVA kits have reported extensive shortages and stockouts over the past few years. And MVAs are certainly needed. In Uganda, there are an estimated 300,000 unsafe abortions each year, of which nearly a quarter develop major complications. In Uganda, MVAs are not procured by the National Medical Store, and they cost about $50 each on the private market through a local importer. In both countries, the private sector provides a significant share of facility-based deliveries despite its cost. Women who are able to often choose private sector facilities for perceived higher quality of care and also knowing that supplies are more likely to be available. A study of 50 facilities in Bangladesh found that in making a decision about which facility to go to, the quality of care outweighed accessibility. But when private facilities, including NGOs, rely on the government to procure and deliver their supplies, they are subject to the capacity of the public sector supply chain, or the lack thereof. In Uganda, the faith-based joint medical store provides a procurement alternative to the national medical stores, and it's widely considered to be more reliable. However, it does not provide contraceptives, Misoprostol, or MVAs. In addition, pharmacies and drug shops, which may or may not be licensed or regulated, are a critical source of supply and information for maternal indications and other areas of health. There are 200,000 private pharmacies alone in Bangladesh, and they're often located across the street from the hospital, drawing customers from among the patients and their families who, when they arrive at the health facility to find that supplies are low or out of stock, are immediately dispatched with a prescription for supplies to purchase themselves. Many countries have adopted forecasting exercises with projections of need for contraceptives, which is a critical step in ensuring a stable supply of drugs. But this is less likely to happen for other maternal health supplies, particularly long-term forecasting. In both countries, the supply chain currently operates on a mixed push or pull system, and maternal health supplies are integrated with other medicines within the supply chain. Uganda is making a transition to a push system with a standard kit of supplies that will be delivered directly to the 2 lowest levels of facilities. And reportedly, this kit will include oxytocin and misoprostol for health centers 2, the lowest level of facility, and also magnesium sulfate for health centers 3. But Uganda faces higher prices for supplies because no maternal health supplies that we looked at are manufactured domestically, and relatively few foreign manufacturers are willing to go through the registration process due to its extensive regulations and very small profit margins for drugs like oxytocin. Procurement only happens at specific times, in Bangladesh just once a year. Bangladesh does have local manufacturers for the supplies that we studied, except for MVAs. In Bangladesh, some hospitals receive a specific quantity of supplies based on the number of beds that they have. But they often treat many more patients in reality than they have beds available, which means that the quantity of supplies provided is inadequate. Despite other mechanisms for facilities to purchase supplies, Many supplies, including oxytocin, are typically on a list that's given to patients when they arrive for purchase in a private pharmacy. In both countries, the cold chain for oxytocin, which is a drug that's described as being relatively stable at temperatures below 30 degrees Celsius. Centigrade. Science is not my forte. The cold chain for oxytocin is described as being maintained sometimes. And I've included a quote from a 2003 Maternal Health review by Makerere University, which demonstrates the severity of supply shortages at the facility level. Even when supplies are available, especially true for MVAs, providers may not use them because of a lack of confidence in their training. I've included here a quote from a government official that we interviewed in Uganda about the infrequency of refresher training. In addition, regulations can inhibit the use of certain supplies or equipment. So Mulago Hospital, the largest national referral hospital in Uganda, previously did not allow MVAs to be used at all during night hours because of a concern that lower-level health staff would use them inappropriately. The focus on community-based care within these countries varies. In Uganda, stakeholders widely agree that the transportation and referral system is not adequate to address complications if a woman is delivering at home, and they emphasize facility-based deliveries. However, Uganda is rolling out village health teams, which will be able to provide misoprostol, but as of last year, these teams had been implemented in less than half of the country's districts. In Bangladesh, the efforts to increase the share of facility-based deliveries have not met with much success over the past several years, and community-level service delivery is a major focus there. The community-based skilled birth attendance program has been revived in Bangladesh in recent years, with a goal of training 1,000 new health workers each year. And these workers will be able to carry oxytocin and misoprostol with them. However, the stakeholders we met with were unsure of whether there is a specific process to resupply these agents within the community. Our research highlighted some entry points that were identified by the stakeholders we met with to strengthen the supply chain for maternal health commodities. Among these are streamlining the registration process and conducting both annual and long-term forecastings of need, utilizing lessons learned from contraceptive procurement. Countries must also be sure to ensure the quality of locally manufactured products. As I mentioned, Uganda is implementing a push system to low-level facilities, but one size does not fit all. The quantities and method mix must be adaptable. Between a growing number of women of reproductive age and the effect of continued investments in these programs, demand is likely to steadily increase. Few donors are providing vertical funding for maternal health supplies as they do for contraceptives. But the impact of their health and general budget support is weaker when government-funded supplies are out of stock. There are various mechanisms for donor and government cooperation within the health sector, and supplies should be part of their agenda. Logistics system strengthening is an important component of donor-funded projects to build sustainability in the health sector. And as the use of misoprostol becomes more widespread, governments will have to plan for incorporating it into their budgets, training providers, especially if it is in fact distributed at lower levels, and adding it into the supply chain. And I'll conclude with a few additional entry points that we hope can also strengthen the availability of maternal health supplies. First, strong policies exist and continue to be developed, but they haven't yet resulted in sufficient funding, and they're often implemented slowly. Uganda has a new Reproductive Health Commodity Security Strategic Plan, which budgets costs for all 4 of the supplies included in this research. And they also have a roadmap for improving maternal mortality and morbidity. And this spring, Uganda's Deputy Speaker of Parliament called for a new Ministry of Maternal Health. But a Ugandan government official that we met with reacted to all of this, saying, "The ministries and president say, yes, we support, but there is nothing in tangible terms." So supplies can be an indicator to monitor the success of policies that look great on paper. This also must include disseminating guidelines and protocols to ensure clarity about which health workers can distribute which products. Second, community outreach is imperative to overcome the first delay, the delay in deciding to seek care, and the perception that maternal health is a woman's battle. Bangladesh has taken many steps toward the community-based distribution of supplies, but they must ensure that as new cadres of community workers are trained, they have continuous access to needed supplies. In Uganda, where transportation and infrastructure are major concerns, community outreach can promote utilization of facilities. Third, family planning has direct and proven links to reducing maternal mortality and fulfilling a fundamental right to health care. It's a proven quick win to improving maternal health by reducing unintended pregnancies. But Uganda has one of the highest rates of unmet need for family planning in the world, and unmet need in Bangladesh has recently risen. So family planning must be a national priority and integrated into all maternal, newborn, and child health programs. Budget monitoring is an area where advocates have already developed a strong role. Allocations for these supplies do exist within budgets, but expenditures are often just a fraction. Here, in budget monitoring, advocates can ensure adequate lead time for planning and carefully monitor disbursements. Finally, human resources present a constellation of challenges, and without addressing these, maternal health cannot be significantly improved. Both governments are rolling out more community health workers, but their training is sometimes considered to be too short, and refresher training is infrequent. High-level health workers in the public sector are low-paid and overworked. The health center 4 that we visited in Kampala had a single doctor who was individually on call 24/7. And it was similar with a high-level facility in Bangladesh, where turnover and absenteeism are described as major problems. Providers are even less available in the rural and hard-to-staff posts where they are critically needed. So governments must address these interrelated issues of compensation, motivation, and training. Thanks very much.
Elizabeth, thank you so much for a really great overview of the issues that we're trying to grapple with today, and for doing it so clearly and succinctly. I think for me that what you've really highlighted is not just an issue about supply chain management. This is really an issue about all the other barriers that are also in place once we even get the supplies. And those barriers include things around service delivery, around some of the socio-cultural barriers that women face, and around many of the legal barriers, including regulation of some of these commodities per se. I think you've given us a lot of food for thought for our conversation as we move forward this morning. I propose that we go straight on and ask Melodie to do her presentation, but I wonder if anybody has any just immediate points of clarification that they want to ask Elizabeth in terms of her presentation. Great. I take silence being everybody was fully understanding what you've done, which is great. In which case, I'd like to move on and ask Melodie Holden, who is the founder and CEO of Venture Strategies Innovations, to talk to us about the specific work that they've been doing on Misoprostol. Thanks, Melodie.
Thank you. It's delightful to be here today. Thanks to all of the organizers. So Elizabeth has just presented an analysis of the availability of maternal health supplies in 2 countries, and I'd like to follow on that with a case study of Misoprostol and tell the story of how to make it available to women in need. So the title of my presentation is Getting Products to People. I'll share some of the strategies that we at VSI and our partners in the Ministries of Health and other agencies, including social marketers and commercial distributors and NGOs, have used to create access to Misoprostol for postpartum hemorrhage and other obstetric use. The story of Misoprostol is still being written. And throughout my talk, I'll be giving an update on some of the key milestones in the regions where we work. I'll end with a discussion of some of the challenges and solutions and what remains to be done. For those of you who don't know VSI, we're a nonprofit committed to improving women's health by creating access to effective and affordable technologies on a large scale in developing countries. Our model is to invest in creating access to interventions that are low cost, relatively simple to use, and address a major burden of disease. We often look at older technologies, drugs, devices, and techniques that are now in generic form, proven in clinical use, but unavailable in sub-Saharan Africa and South Asia. We have programmatic expertise to conduct the activities on the left of this slide for creating access ultimately to interventions. Our flagship program is around the generic drug Misoprostol. Misoprostol, as Elizabeth introduced, comes as a heat-stable tablet. 3 tablets taken immediately after childbirth are effective at reducing the bleeding. And excessive bleeding after childbirth or postpartum hemorrhage accounts for 25% of maternal deaths globally and 34% in Africa. 99% of these deaths occur in developing countries, where women most often give birth at home. And that's the focus of our intervention, where women are far from a health facility or a skilled provider. Any woman can take Misoprostol to prevent PPH, postpartum hemorrhage. The tablets are taken orally, and side effects are manageable at the household level, making it an ideal public health intervention in rural areas. Misoprostol is complementary to other postpartum hemorrhage interventions like oxytocin and the anti-shock garment. When we got involved with this project in 2004, this is an approximate view of the global register, or in these regions, registration status of Misoprostol. So what does it take to create access to a product like Misoprostol? When we started this program, it was used widely in the US and in Europe under the brand name Cytotec, but it was largely unavailable in sub-Saharan Africa and South Asia, the places where the rates of home birth and postpartum hemorrhage are the highest, so the need for the drug is the greatest. When it was available, it was through small quantities, imported for a short-term project or purchased on the black market. It was often costly and of uncertain quality. In some cases, it was registered for gastric ulcers, which was its original use, but such a registration typically doesn't allow for it to be used legally for obstetrics. There was solid research in clinical settings and years of use in Western hospital, but little operations research showing how to deploy it in a rural, developing country environment. In 6 years, the map has changed dramatically. 16 countries have at least one Misoprostol project registered for postpartum hemorrhage and/or post-abortion care on the market. All of our work in facilitating this process is South-South trade, using local distributors and manufacturers from developing countries. There is momentum, and each year more and more countries are approving Misoprostol for obstetric and gynecological use. Check our website because more are expected in the coming year. Registration is the legal authority to import, market, and sell a specific product. A registration specifies how to use it and where it can be sold. Registration is a crucial first step, but it is just the first step toward availability. So getting products to people. What does it take to move beyond that first step of product registration and create access for the woman in her village? The answer takes us back to Economics 101, supply and demand. The solution is to simultaneously provide supply and generate demand. Simple, right? So how do we create supply? And I'm going to go in detail on several of these topics. But the overview is that first we obtain registration of a high-quality product. Regarding quality, Misoprostol, like all drugs, needs quality assurance at the manufacturer's site, throughout the supply chain, and ultimately on the shelf as we monitor expiration dates. Fortunately, Misoprostol is heat stable and has a 2 to 3 year shelf life, so it's not as difficult as some of the cold chain products. Second, we examine all the available channels of distribution in the public and private sectors, and select to focus on those which have the greatest potential for impacting women. We look at policies and procedures to help governments update their local technical documentation to reflect this newly available product. Third, we're just beginning to work with distributors and governments on demand forecasting, establishing regular procurement. Over the coming years, we'll be looking across the often complex logistics systems at what can be done to make the best use of the existing infrastructure. Then on the demand side, we must have a product that is acceptable to women, engage communities to educate and mobilize women, train providers at all levels of the healthcare system, and provide support to distributors to jumpstart sales and marketing. Finally, with regards to pricing, as supply and demand increase, we can examine prices, driving costs out of the system to meet the needs of the underserved. If we can get these factors right, which is an ongoing process, and then we can analyze whether product distribution is sufficient to address the needs of women and create a lasting impact. I'm going to provide additional details about how to approach several of these steps. First, regarding distribution channels. If you're looking to maximize impact by scaling up an intervention, developing a distribution strategy will be one of the most critical elements of your work. At VSI, we map out an entire country's of available distribution channels, which are the links from the manufacturer and the distributor to the end user. These are the physical ways that drugs flow throughout the system. Each country has its own mix of elements on this slide. As much as you can, quantify the size of each of these channels, which means how many providers or outlets exist and how much of our target population reaches them. We start from left to right, describing the existing infrastructure. Then we work from right to left to select the channels that are the most effective and likely to reach women. Most often in Africa, the channels with the highest potential for reaching women are in the mid and lower level providers and outlets that, while not highly skilled, are the most likely to be available to women in need. For our intervention in particular, a woman with postpartum hemorrhage only has about 1 to 2 hours to get care, so we must ensure that the solution is available in her village. Next, regarding government policies, another important piece to this puzzle is the role of governments in establishing policies that support a new intervention, establishing who can use it and for what indications. By including misoprostol in national guidelines for mid and lower level providers, ministries of health open up access to far more of its population than could be reached through hospitals and clinics alone. Governments require scientific evidence of an intervention in order to approve this, which is why VSI has done operations research on postpartum delivery at the community level in 9 countries. Adding misoprostol to a national essential medicines list often establishes it to be duty-free or procured through the government purchasing system, so it can be a key piece. Throughout our work, we have assisted 7 countries in updating these local policies. Establishing policies around a new intervention not only establishes its reach, but makes its use institutionalized, which means it will be part of a system even if governments or individuals change. Next, a word on pricing. In our work ranging from governments to individual buyers, the issue of price is one that cannot be ignored. VSI has negotiated the world's lowest prices for misoprostol, reducing it by 150% since we started this work. Even so, families in the lowest quintiles are still sensitive to cost. To address this, we break down the elements of cost from the manufacturer to the end user. Every step along this chain adds a percentage. We look at creative ways to reduce costs at every step along the chain. For example, achieving a duty-free status to reduce customs and duty fees, negotiating bulk purchases with multiple agents to be able to reduce shipping charges and provide leverage with manufacturers. At 3 tablets, even including all of the elements of cost along this system, the price of each birth protected from postpartum hemorrhage right now is about 80 cents. That's roughly the cost of a month's worth of oil. Now we switch to the demand side. We looking at the acceptability of the intervention. We've done operations research in these 9 countries examining the safety, acceptability, feasibility, and effectiveness of providing misoprostol directly to pregnant women at various gestational ages. We've enrolled over 147,000 women combined in these programs. The data is beginning to come in, and we're seeing that when misoprostol is available, women use it, and far more births are protected from life-threatening postpartum hemorrhage. In some of these situations, like our program in northern Nigeria, misoprostol protected 79% of the women in the project area who would have otherwise had nothing to prevent life-threatening postpartum hemorrhage at home births. When simple educational messages on how to use misoprostol through IEC campaigns and counseling are delivered, women remember and use it at the correct dose and route. And finally, women recommend misoprostol and are willing to pay for it. Our data from 3 countries, Nigeria, Tanzania, and Zambia, showed that rural women are willing to pay between $1.12 and $3.50 for a 3-tablet dose. Interestingly enough, in our program in northern Nigeria, husbands were some of the strongest proponents of misoprostol, and in the majority of the cases, they were the ones who procured it for their wives. People are willing to make sacrifices to have access to misoprostol. In order to reach scale, success will be determined by how well we integrate this new intervention into the work of local agencies on the ground. This slide shows examples of IEC materials that are developed to each country's local context and a training of trainers. One of our critical success factors has been the wonderful partnerships that we've developed with ministries of health, with social marketers like PSI, DKT, and MSI, with commercial distributors, and a myriad of NGOs, both local and international, like Pathfinder, JPIGO, IPPF, Gender Health, PATH. These agencies and professional medical associations, community and women's groups that are actively on the ground reaching out within their communities to reach women at the greatest potential. These agencies are well positioned to deliver messages, information, and products to women. We achieve far more together than we could on our own. So this model, this approach to making products available, is not without challenges. And I want to share with you some of the solutions that we've put into place to address them. For example, with misoprostol, on the far left, it's a highly sensitive product because of its alternative uses for abortion. We found that local champions are the most effective advocates for misoprostol in their countries, and that policy meetings provide a venue for scientific evidence to be analyzed and all voices to be heard. The need to institutionalize the intervention is about including it in the technical guidelines for each country so that its use is part of the local infrastructure. We found that local policymakers are effective decision makers when provided with scientific evidence. Part of institutionalization is also disseminating the updated guidelines throughout the provider community at all levels of the health system. The lack of trained providers is so predominant in any discussion of healthcare in these environments that in cases like misoprostol, it becomes critical for the use of task shifting and task sharing. So reducing the level of access that's required for accessing an intervention like misoprostol is a component of providing this healthcare. The challenge of rural and remote environments is addressed by mapping local agencies and working in partnership with those on the ground to reach the maximum coverage, and also by engaging both the private and the public sectors working together. And finally, the challenge of high prices is addressed by breaking down all of the elements of cost to the end user and working to reduce each of those elements with some of the techniques like price competition with more than one product on the market, subsidization through social marketing, and bulk purchasing. So what remains to be done? First, I should say that what I described today is done on a country-by-country basis. So the map is far from filled in, meaning we have far more countries to go that need access and want access to misoprostol. For those countries where a registered product has been around for a while, the next phase of our work is really centered around alignment. And that means aligning the training and community mobilization and product marketing and distribution activities that are going on in a country and making sure they're all working together so that the right product is available at the right time. Additionally, public and private sector distributors need support in forecasting, procurement, and sometimes the logistics of delivering a product. Quality remains an important issue, particularly as we begin to see products in the field meet their expiration dates. And finally, we as a community need to be looking at the level of impact that we want to see from the misoprostol for postpartum hemorrhage intervention and working backwards to evaluating whether or not we're reaching maximum potential. If there is a gap between what could be achieved with misoprostol and what is, then we need to go back to the model and figure out what pieces aren't working. The work is complex and takes time, but it's worth it. The need is evident. I want to share with you a few quotes from our program. The first one is an antenatal care provider in Zambia who said, "Thank you to those who have provided us with this drug. You have given us pride." And she followed that up with "make sure that this product is always here for us." The second is a mother who had had postpartum hemorrhage in northern Nigeria. She said, "I had nightmares when I was pregnant because I feared bleeding. I'm grateful for Misoprostol for protecting me." And finally, a community volunteer named Richard in Zambia. When our evaluators came back to look at the program that we had done there, the program was to deliver Misoprostol to women at any gestational age, to pregnant women at any gestational age, which was really important for a country like Zambia, where the seasonal changes make it very difficult to access a clinic at certain times of the year. This man, Richard, he wrote out an incredibly detailed and beautiful report, handwritten, carefully done, very well thought through and organized. And he came up to our evaluator and he said, "You need to understand something. As men, we are the grave diggers in our communities. Since this project came, we have not dug any graves for our women." By looking holistically across an entire healthcare system, bringing in great interventions, addressing the components of supply and demand, and working with local partners, we can have lasting impact. We've come a long way, but there is a long way yet to go. 300 women die each day from postpartum hemorrhage. Many individuals and agencies are coming together to be part of this journey, and we welcome you. Thank you.
Thank you, Melodie, so much for a really informative presentation on one key product that many of us are familiar with. And I think not just in terms of the supply chain and the logistics, but really putting the human face to it. The quotes at the end really mean that this is not just about getting commodities out. This is about saving women's lives with really simple products that we know that we can do. We've got exactly an hour now for an open discussion. So I'm really keen to hear the views from all the people who are here in the room today. I'm sure you've got a lot to say. I mean, I think if there's a couple of things I just want to make a point about. One is that it's often said that the family planning or the reproductive health community and the maternal sort of newborn and child health communities have very different views of supplies, that their views are fundamentally different, and therefore it leads us to go down two separate paths. I think it's worth saying, as Jeff said at the beginning, my role in DFID is as the team leader for the AIDS and reproductive health team. And within that, I have three policy areas that my team lead on. One is on sexual and reproductive health and rights, one is on maternal, newborn and child health, and one is on HIV and AIDS. So I straddle lots of parts of the continuum, but I often sit with a different hat in a different group. So in addition to being the chair of the board of the Reproductive Health Supplies Coalition, I'm also a board member of the Partnership for Maternal, Newborn and Child Health. And what I often see is that we do sit in these distinct places with a hat on thinking about these issues, but actually we recognise that we need to explore the continuum. So I'm keen to hear people's views on whether this is a false dichotomy or whether it's real. And if it's real, what do we need to be doing? And if it's false, how do we try and build those bridges so that we're not having the same discussions in separate rooms with different hats on? Let's open up the discussion now. As Jeff said at the beginning, if you can introduce yourself, because we're on live webcam around the world, so people need to know who you are. If you can wait till the microphone arrives and then speak clearly and loudly. Let's take 2 or 3 comments or questions, and then let's go back to the panel for comment, and let's open up more broadly. So first, down here. If you just want to wait for the microphone so people around the world can hear you.
Hi, I'm Debbie Armbruster, USAID. And mine are really just questions, and this is kind of getting an update from Melodie. So I was wondering, at this point, what's the lowest cost you can get for Misoprostol? Last I heard, it was between 10 and 12. Are there any governments that are actually now procuring Misoprostol? And who are they getting it from? And how many manufacturers are you now working with? Sorry, this is just a kind of a list of... and then the last one is, who do we have now making 25 microgram tablets? Because we're not talking induction, but I think that's actually a huge piece of where Misoprostol is going to get used, or is being used.
Okay, let's take a couple more questions and then come back. One over here.
Yes, I'm Elaine Foltz, and we are consultants to the UN as One project on maternal health in Tanzania. And we're going to Tanzania on Thursday for further discussion of that project, including Misoprostol, which is high on the agenda of this UN meeting. So very happy to be here and hear both of your presentations. I wanted to ask you how you see the pros and cons in the debate about giving Misoprostol for prevention versus treatment of postpartum hemorrhage once it occurs. We have read in the literature and had some discussion. I know there is a point of view that says maybe we should start out with treatment as a first step, and I just wonder how you see the arguments on that.
And the third comment before we go for response? Yeah, right at the back.
Hi, I'm interested at sort of the policy macro level with a lot of the government clinics. How do you make maternal health commodities make the case that they need to be very high in the supply chain and the budgetary needs? I mean, you walk into these clinics and there are just so many needs and they're stocked out of everything. There's a lot of donor funds for HIV, TB, malaria commodities. So how do you make maternal health a competing priority?
Sorry, can you just give your name and
Sarah
organization?
Malillo from CMMB.
Melodie, do you want to have a go at answering a couple of those to start with?
Sure. Thank you. All right, so the price is between 5 to 10 cents now per tablet. So when I gave the overall 80 cents, that was a price to the end user. So that included all the elements of price, including taxes and margins along the way. But the base price from the manufacturer is now 5 or 10 cents per tablet, depending on the manufacturer. There are, I believe, 3 governments procuring Misoprostol directly, and they're buying it from the locally registered product, whatever that one is in the country. The manufacturers that we are working with are 4 right now. 1 in Egypt, 2 in Bangladesh, and 1 in Pakistan.
What happened to Taiwan?
No, Taiwan.
Okay.
Yeah. And then the 25 microgram tablet, I believe that one of the Indian manufacturers, actually I take it back, Egypt was planning, that never got it. Yeah, and actually I should have said there's also an Indian manufacturer, so 5 manufacturers we're working with. 25 microgram, one of the Indian ones, I believe, is making that now. Prevention versus treatment. So both work. Both are viable. We've actually looked at both in the field, and you can use, in fact, we did a treatment study that looked at its use by traditional birth attendants in western Tanzania, and it worked very well. I think it's going to come down to the local environment and what makes most sense for a given community. Typically, prevention is picked up as a simpler messaging because all women can take it. Treatment is a little more complex because it involves measuring of blood loss, which can be difficult. But I think what's most important is that all options are available for women who need it.
Elizabeth, do you want to give some thoughts?
On the question about policy issues and how to prioritize maternal health with all of the various other competing priorities, that's a great question. I would say that our community is tremendously helped by the fact that we have a Millennium Development Goal dedicated to maternal health with 2 quantifiable targets, and it's a commitment that almost all governments around the world have made. We are also perhaps helped by the unfortunate fact that progress towards that particular Millennium Development Goal has been among the slowest, despite the promising new research that's come out this year showing a decline in the number of maternal deaths. Maternal death remains a leading cause of death around the world, and I think governments understand that it's tremendous and preventable devastation to their human resources, not only to the women who die, but also to their children and their families. And as with other reproductive health commodities, like those for family planning, the supplies that we're talking about, with the possible exception of MVA, are generally quite low in cost, and all of them are highly effective. So I think those are some of the key points that advocates in this field can try to make, and often be met with with a lot of receptivity, as we've seen from some really strong policy documents. The challenge is just, as you said, making sure that those words on paper translate into implementation and action on the ground.
Thanks. So let's go for another round of comments, but I'm also keen, recognising the expertise that we've got in the room, that we don't just have a dialogue between people on the floor and people on the panel. I'd like to try and encourage a broader dialogue, drawing on the expertise and knowledge that all of you in this room have. So broader comments, questions for each other as well as for the panel will be gratefully received. Who wants to go first or next?
Hi, my name is Rami. I work for the U.S. Department of Health and Human Services in their Maternal and Child Health Bureau. I have a question for Melodie. In your presentation, one of the key things is building bridges between the governments and the private sector. So I was wondering, could you share some of your thoughts on some of the strategies that you may have used? And I am asking this question curiously because I know I was born in Nigeria and you have done some great work in the northern part of Nigeria. So I was thinking, how were you able to build that bridge?
Tim, over here.
Tim Thomas from the Maternal Health Task Force. One for Melodie. What's the scalability of the Northern Nigeria experience and replicability as well? I know that there was some talk about extending that idea into India, and I wonder if there's been any movement on that. And then one from Elizabeth. You talked about supplies, commodities, and products in your vernacular equaling medicines and equipment. Can you go into detail on the equipment and the feasibility of that essential equipment being part of a maternal health supplies procurement effort?
Jeff at the back.
Thank you very much. Perhaps for anyone on the panel, expand on the question of getting out of our stovepipes and getting some of these different communities to work together. Obviously, family planning and maternal health here. But do you have some specific examples of how some of those divisions that come from different pots of money, different earmarks, different systems, how you've seen people overcome the difficulty of those communities working together? I mean, Julia alluded to how she sits in a couple different worlds, even just in her single post. Ways that this is being overcome, because we've seen it certainly in many of the discussions here, where a lot of times the communities are in the room together, but there's still some challenges in getting them to practically work together. So your thoughts on overcoming some of the bureaucratic stovepipes that afflict so many things in development. But if you have some good models and good examples that you can point us to, that'd be terrific.
Melanie.
All right.
Melodie, do you want to start first?
Well, I really like the questions, and I think that they would be great for the kind of discussion that you're looking for back and forth. So I can give a few ideas. Related to the public and private sectors working together, this is one of the things that has been really exciting for me to watch. And of course, as we know, each country has a different mix of the public and private sector. A country like Nigeria that has a very strong private sector presence, and a country like an Ethiopia or a Mozambique that has a much bigger public sector strength. And so what's important is first taking a look at that diagram that I showed, where it had them from the manufacturer to the end user and all of the different channels that are available. So some examples of how this has worked. So is a country like Ethiopia, where in northern Ethiopia there are health extension workers. And health extension workers are at the village level providing services directly to women. So that's a government system, and it's an excellent channel for reaching women, and one that we've used in our work there. But there's also a need for supply of the product, and the product is not always available through the public sector system. So you've got an organization like DKT that has a registered Misoprostol product that was able to supply the commodity in that case. And then you have women's groups who physically reach out and touch a huge portion of the population in Ethiopia, and particularly in the regions where we were working. So those kind of private sector groups did a lot of community mobilization that helped engage women, sending them to the health extension workers, and then using a product that in some cases was supplied through the private sector. So that's one example of these agencies or these different players in the system working together. It's really been about focusing on the end goal of reaching the largest number of women with the information on how to use it correctly. And so I don't have any magic bullets for addressing bureaucracies and stovepipes, but when we've been able to get people around the table and start with that goal, we've seen some really tremendous commitment to getting those things done. Some of the key players that have been involved in every country we've worked in have been, of course, the Ministry of Health and the professional organizations, the professional medical associations. So the OBGYN Society, the Nurse Midwives Organization, that have been real advocates and real bringing together of different people for that ultimate common good. So does that give you an answer to your question on public and private sector? Does that answer? Okay. So most of our programs have been providing misoprostol directly to pregnant women through either antenatal care or community health workers. Northern Nigeria is an interesting case because in Northern Nigeria the infrastructure really doesn't, there is just pretty much no infrastructure. The public sector isn't there, the private sector isn't there. So it was a challenge to try to figure out how to build a program there without what we typically do, which is leverage existing infrastructure, right? It's one of the most difficult places in the world to be a woman. Women are largely sequestered in their homes, so even getting access to them is incredibly difficult. So what we did in Northern Nigeria, which is unique, a unique situation, is to provide dance troupes and community building through drama groups that went into communities and brought awareness of the potential solutions to addressing postpartum hemorrhage, of which women were quite well aware from their own experience. And then to follow that with community drug gatekeepers, which were people that were assigned or organized by the communities themselves to be the ones that held the product. And these are women that wore hijabs, white hijabs with the Misoprostol logo on the hijab. And when they would come into a community, they were very actively pursued by the people of the community that had learned about this intervention. So scalability and replicability. We wouldn't have done it if it didn't have potential for scalability and replicability. That said, it's one of the more challenging ones because of the lack of existing infrastructure, which is normally what we plug into. There was a cool story that comes out of that area in northern Nigeria that a woman who was pregnant, she's a traditional birth attendant, and she received the training as part of our kind of community mobilization efforts about postpartum hemorrhage. She had her misoprostol tablets with her. She was also educated, just like in every one of our programs, that the best thing is to get to a health facility. In fact, in our programs, we've seen no change in no substantial change, and even in most cases, a small increase in women going to facilities after they learn about misoprostol because they kind of see the relevance of that health facility. Anyways, that's an aside. So this woman, she had her misoprostol tablet. She did choose to deliver at home. She was by herself. She delivered her baby and then felt around and felt a twin. So she delivers her second baby. And she starts to feel herself getting weak. And as this is happening, she reaches over and she takes her misoprostol tablets. And when our country manager went back into the field several months later, she was sitting with her 2 children, living to tell the story. So it does work, but it does take creative solutions in an area like that. I think the other question is for you.
Yeah. So Tim, you asked about equipment and what that means within the lexicon of supplies. So equipment, certainly an MVA is an equipment rather than a medicine, and things like supplies for C-sections, even expendables, gauze, and would all, I think, fall into that category. One of the challenges we've seen is a separation of funding for medicines and equipment. I mentioned the credit line for medicines in Uganda, which has been largely funded by DANITA. There's a separate credit line for equipment. DANITA was also the largest bilateral funder of that. So that leaves two challenges for the government. I only mentioned one, but it will create some important funding challenges for both equipment and medicines. There's also challenges in Bangladesh, which happens to have a split health system structure with two parallel directorates, a Directorate General of Health Services and a Directorate General of Family Planning, both of whom procure supplies using different pots of money and fund equipment and medicines in different ways. In fact, MVAs are not available through one of the directorates. Misoprostol is not available through the other directorate. Both of them have facilities where women seek reproductive and maternal health care. Jeff's question, and I hope Julia and Melodie and others will chip into this too, on the ways in which stovepiping is being overcome. Well, my immediate thought about that was that it continues to be a bit of a challenge. And I think one of the biggest reasons for that is because of the separate funding or the different channels of funding for family planning versus maternal, newborn, and child health. Because as I mentioned, family planning continues to be largely donor-supported through vertical procurements. And I think in some cases, governments may expect that to be the case for the foreseeable future and expect that they can rely on those shipments continuing to come in large quantities. Whereas maternal, newborn, and child health are often something that they have to fund together with donors. We did learn about a lot of promising new integrated projects during the course of our research, including the policy level work on the global scale that the Partnership for Maternal, Newborn, and Child Health oversees. The UN has a maternal newborn health project in Bangladesh, and of course USAID's new project MCHIP integrates maternal and child health. Now you'll notice that family planning or reproductive health is not necessarily in the title of any of those projects, but I think we were very heartened because when we went both here in the U.S. and in each country doing this research, people who maybe didn't know PAI would say to us immediately, well, you're missing a huge piece. How can you be leaving out family planning? Why did you not choose contraceptives as one of your supplies? And then we also would hear from service providers identifying contraceptives as one of the most critical commodities in preventing maternal mortality. So I'm not sure how much of a stovepipe it still is at the service delivery level. I think health workers and practitioners are fully cognizant of the need for an integrated approach. But I think at the policy level there are still some debates and differing approaches.
Jeff, my view is that's absolutely the right question for us to be asking, and it's something that I feel I spend a lot of my time doing, which is trying to be a marriage broker between all the various constituencies that we work in. And so, for example, one of the things that I think we've done successfully, although it's still very nascent, is getting the Reproductive Health Supplies Coalition to be a partner of the PMNCH and getting the PMNCH to be a partner of the Supplies Coalition. So that dialogue is now just starting. The next step on my plan for that one is that the PMNCH has 6 priority areas that it works for, and PA3 is around commodity security. And so my conversation in the board meeting of PMNCH is there's a whole organisation called RHSC, who's now a member of your organisation, whose job it is to do that stuff. You guys should be talking to them rather than having a separate work programme that happens. So that's sort of going on. But I think for me the real value of joining all this up is that I just think we've got such a great window of opportunity, and that if we try and work together, it's not a zero-sum game. We can really start to energise the issues that we all care passionately about, which ultimately is about saving women and children's lives, and that actually we all have a piece of the puzzle to make. So I think there's really great value in trying to break down these you call them stovepipes, we call them silos, to trying to break down these silos to really bring those powers together. And I think for those of you who aren't aware, at the UN Secretary General's event on women and children's health in September, USAID, DFID, the Gates Foundation, and the Australian aid department, AusAid, launched a new alliance on reproductive, maternal and newborn health. So again, trying to bring some of this together. Now, of course, we've been criticised that it's not the full spectrum because we didn't include the child health. But I think we have to be opportunistic and seize opportunities when they arise. And there was a real moment there with the political interest that exists within the US government, within the British government and within the Gates Foundation for trying to advance the sort of MDG 5 agenda, which of course includes the sort of, I hate to use the term, but the collateral benefit that we see from the newborn of improving reproductive and maternal health. And so there was a real clear opportunity to bring that alliance together. It was very interesting, for those of you who were at the Women Deliver conference that was held here in Washington just a few months ago, a really powerful speech that was done by Melinda Gates that said women are not fistula, they're not tuberculosis, they're not vitamin A, they're not whatever. Women are women who have complex health needs, and we need to design a system from a woman's perspective rather than from a vertical supply perspective. And I think that's a really powerful way of framing the conversations that we need to have, because I think too often we come at it with a very silo, this illness or that disease or that complication, and actually we need to be doing a bottom-up holistic approach that really supports the services that women need throughout her life cycle and at different times. And I think if we start thinking about it that way, we might have better success. Hey, lots of questions. Finally, right. Hopefully not for us. Discussions between all of you. Let's start here, the lady at the front.
Thanks. My name's Carolyn Hart. I'm with John Snow Incorporated. And we do a lot of work around public health supply chains and contraceptive security and commodity security. And I am not going to speak in favor of vertical programs or stovepiping, but I am going to say that after 25 years of working on this, one thing I've learned is that as, I forget, Oliver Wendell Holmes or somebody said the price of liberty is eternal vigilance. Well, the price of commodity security is eternal vigilance about the product you care most about. And I think that it's okay to be passionate about a small list of products and to work, as Julia, as you said, to try to create places where we talk to each other and create opportunities for synergy and mutual benefit and economies of scale and things like that, and leveraging infrastructure, as Melodie mentioned. But I really don't think the list, any one person's list, needs to grow to the entire list of products necessary for mothers' and children's health, and that it's really okay to kind of marry advocacy messages about a specific product, even, or a small list of products in that kind of quest for then meeting one person's whole health needs. And I just wanted to say that to everybody.
Did you have your hand up there? I didn't, but I'll take it.
Someone, I'm sorry. Should I give it back to you?
Oh, someone over there.
Yeah. I talked. There's a couple back there.
Hi, my name is Leslie Pedicewicz, and I'm from JSI as well. Elizabeth, you started off talking about the 4 tracer drugs that you all focused on, and there was agreement about that. But I wonder if, I know that there was challenge in sort of determining the sort of the comprehensive list of equipment and supplies, and I wondered if you could speak to that. Also, in my mind, one of the challenges with that is that within a broader list, there are variations within that list. So there are some commodities that are preventive, and then there are some that are curative. And so within that, you've got different priorities and different focus. And if you could speak to that.
Did you want me to go ahead and ask? Okay. Hi, Kate Valenberg with Plan USA. Just to kind of narrow down a little bit again about advocacy, I'm a technical person, but over the years appreciate advocacy more and more as it opens the door to budget lines and supply chains. And I was wondering if somebody on the panel could speak to some of the barriers, specifically with Misoprostol and some of these drugs. Some of them are seen as abortifacients. Abortion is illegal in a lot of places. So in terms of access, if you guys have any stories, I've come up against this in a lot of my work as well, with high-level national ministries and officials at that level having barriers there, and also access to unmarried girls or adolescent girls. If you have any experience or could speak to that, that'd be great.
That's great. I think we just do a few responses to this and then do another round. I mean, I think just to respond to Carolyn's point, I mean, I think you're absolutely right. It's not at all about making us all sort of lowest common denominator. I think it's about recognising individual. And I think the work that VSI have been doing very specifically on a very key market is absolutely key. But it's how we can draw that into the broader community and the broader lessons that we can learn and build on and share with the work that we're doing. It's interesting, a colleague of mine at Gates always talks about oatmeal, and there's a real risk that if we try and put everything together, we just end up with oatmeal that's useless to everybody. And it's not at all about doing that, but it is about recognising that actually we're all facing similar challenges, we've all got similar concerns, we're all ultimately after the same goal, and that sometimes working together under broader umbrellas helps to advance the agenda, but recognising the absolute need for critical expertise and specialism in some very key areas. Melodie, Elizabeth, comments?
Sure. So also related to this conversation back on the public and private sector mix, because from my experience, it's really not about us sitting in Washington trying to figure it out as much as it is about going into the countries and working within the context of their strategic plans and strategic frameworks. And so a few examples with Misoprostol in particular, in Bangladesh, the government sat down and mapped out regions and had different NGOs take those different regions as far as integrating the Misoprostol work. In a country like Zambia, the Ministry of Health is integrating Misoprostol into antenatal care, whereas PSI is coming in and doing a lot of the IEC campaigns around it. In Tanzania, there's a commercial distributor that is selling to the government, and again, PSI is doing a lot of the social marketing campaigns around it. So a few more examples of how you kind of set aside some of these structural differences and just work on what are the components of getting it out to the end user, and how do we bring together the public and private sector for that. So the other question now I'm blanking on. Political sensitivity. Definitely. So Misoprostol is a highly sensitive product, like you said, because of its dual uses. And we expected this to be a bigger barrier than on the ground than it has been. When countries have been given, like I said, scientific evidence of how this can work in their communities, and when they're given a forum through policy meetings, discussions, technical working groups, to be able to express some of these concerns and work through how they would, how they can address them in their communities, we found them to be, in the far majority of cases, incredibly open. It's very difficult to address the challenges of the Millennium Development Goals without Misoprostol. Some say impossible. So the need to do the intervention, the need to make this available has far outweighed, I think, in many of the minds of the policy makers, has been so compelling that they need to address the other issues in order to make sure that it is available. Hopefully that answers your question.
Elizabeth, on the 4 traces?
Sure, and also just a couple additional notes on political sensitivities. For Misoprostol, our impression was that the debate about approving it for postpartum hemorrhage was aided by the fact that healthcare workers had already in many cases been using it for that very purpose, having obtained it, whether it was approved for gastric ulcers or another purpose, or obtained it privately, and as Melodie says, reported very favorably about its use in low resource settings. And on MVAs, I mentioned at Malago Hospital in Kampala the restrictions that had been in place, that those restrictions are no longer in place, about not using MVAs during nighttime. However, I should also add a more positive side, which is we visited a Catholic hospital also in Kampala that it treats a huge number of patients, including for treatment of incomplete abortions that had been obtained elsewhere. And the doctor we met with there was so adamant about the need to have access to MVAs that when he could not get them through the importer in Uganda, he would travel to other countries in the region and purchase them using his own funds there and bring them back so that the hospital would have them. They still don't have enough. But I do think that the effectiveness and utilization of these products and supplies can sometimes, and hopefully will continue to sort of trump the political sensitivities. Leslie, I'll try and answer your question and just tell me if I'm not getting it quite right. But I think you asked for more information about how we selected the 4 tracer supplies. No.
No, it was more the, is there agreement on the wider list?
No. I mean, there's the WHO model list of essential medicines, which is huge. But we did not find any evidence of agreement within the maternal health community on a single list for supplies. And I understand that as part of its work on their priority action on commodities, the Partnership for Maternal, Newborn, and Child Health has been commissioning or working on a list of supplies. I'm not sure if that list has been finalized yet, but we certainly heard quite a few diverse opinions about which medicines and equipment should be on such a list. You know, that's interesting. That's a great question, and that really didn't come up for us. I think because in some cases some of the drugs that are most commonly used can serve both purposes, as the 2 for postpartum hemorrhage can and as MVA can. But no, that wasn't really raised in our interviews.
Great. Let's go here, there, and then back to Debbie.
Thanks. I'm Carolyn Vogel from Population Action International, and I just had a comment from kind of the advocacy perspective and policy perspective. We've all done so much work trying to identify the challenges and barriers, and we're partway there, but still a lot, still more to go. And then we can kind of envision where we want to go and what the ideal situation should be, but then the real hard part is actually how you get there, because we're trying to affect change in people at the policy level, at the community level, at the facility level. And I just wanted to remind people that often, and I'm sure you know this from your experience, where you can affect change is often around one single person who happens to be a champion. So in our work, we need to pay attention whether we're working at the government level or at the facility level for those people who are change makers and who are champions, and then we need to equip them. We can't just say, there's our champion. We need to give them information, and we need to provide them with messages, and we need to fund them. We need to make sure that they're at international forums and can participate in dialogue and, and position them really to affect change, because that's a huge, huge challenge, is affecting change.
Amy Grossman from Venture Strategies Innovations, and I wanted to piggyback on Melodie's comment and speak again to this advocacy piece, because I think it is a really important one, and with regards to misoprostol specifically. And as Melodie opened up, the misoprostol is still being written, and I think it's very fascinating for us to be watching the transition of the drug, in the sense that when we first got into the work, the focus was heavily on postpartum hemorrhage, and that's the work that Melodie introduced today. But we shouldn't lose sight of the fact that the institutional endorsements are very powerful as well. So it was just 2 years ago that the World Health Organization added misoprostol to the essential medicines list for treatment of incomplete abortion and miscarriage. So that's been a huge benefit when we do talk to these important change makers and champions, to equip them with that information, as well as endorsements with regards to postpartum hemorrhage from FIGO and ICM and others. So we can't ignore that aspect. And I think I just want to update you, give another update with regards to the fact that we've resubmitted for inclusion of misoprostol for postpartum hemorrhage, along with Genuity Health Projects, thanks to their wonderful data that was completed in Pakistan. And so that should actually be, if they follow their deadline, posted today, and that's open for public comments and letters of support. So that's an important key in the, piece in this COG, to make sure that we're getting that high-level endorsement, so that when we do have those difficult conversations, which we've all had, because just as there are gatekeepers as well as there are champions, as we all know. And so it's important to also equip those gatekeepers with that important information as well, and be strategic about who you're giving that information to, and making sure that they have the most accurate information and up-to-date information. So I just wanted to plug that and encourage you to write in your own letters of support for that application.
Thanks, Amy. Can we go back over to Debbie? And then I think there was a hat right just on the edge here.
Thanks. So finally I meet Amy Grossman. So congrats on getting that back in. A couple of comments. One, back to the treatment comment you made. I think the issue, or one of the challenges we have with treatment, is if the whole point is you've got women in isolated areas and you want them to be able to ensure their safety, how are you going to treat them? I mean, basically, they still have to have the drugs, because the issue around treatment and prevention is cost. I mean, if it's more effective to just do treatment, do you give everybody the drugs and say, don't use it until you actually start bleeding? So you've got some logistical issues if, in fact, the only thing you're going to do is treat. So, I mean, to me, that's always been one of the points as well. But you do have the challenge, because you shouldn't redose. If you take it for prevention and it doesn't work, then you do have an issue, because you really shouldn't retake it. So, I mean, there's a few other issues around that, but I think this whole issue of treatment, you know, how is this woman out in the bush going to, now I'm bleeding, oh, okay, I want to get treated. Where's she going to find it? So she has to have it anyway. So that's the one thing on that. One of the things I wanted to say, and I think it was something, Julia, you brought up, or maybe it was Elizabeth, the whole issue of women being seen as a whole person and being treated that way. What's been exciting to me, having gone out to a number of rather difficult countries lately, is when I was actually out in the bush and practicing, they had Monday's antenatal day and Wednesday's family planning day. It's gone. Probably not from everywhere, but I was so pleased to see they treat the women and the kids as they come in. Kids can get immunizations, women can get family. So to me, there's been a huge leap in many ministries, because we fought and fought and fought that and didn't get anywhere. So that was exciting. And the two other things. One is, you were talking about the Reproductive Health Coalition, having just come from PATH not so long ago. I also know that the book put out by the Reproductive Health Coalition, or it was UNFPA, PATH, and WHO. As part of that, there's a little purple book that lists the drugs to be includes 3 maternal health drugs. And so, in fact, there already is some linkages, and hopefully, as you're trying for reproductive health drug security, those are included. So it's MAG, Meso, and preeclampsia, MAG sulfate and oxytocin. So, I think there is already work on that. And I do think even Hans Hogerziel and the group at WHO are thinking about it that way. So that's important. Lastly, you guys aren't giving yourself enough credit in terms of how Misoprostol and how it's working and how you work. I do think IPASS was the leader in how to do this. But the strategy that VSI uses and the strategy that IPASS use, which is, as you're going in, you're very thoughtful about the countries you choose, because often recognizing, is there a possibility to get in, identifying the champions right off the bat, and being very careful and thoughtful about how you manage the process of getting meso introduced in a country. So, give yourself credit. I think some case studies should be done on both you and IPASS and on effective strategies for how do you do this, because I think you do an incredible job. Even with WHO against it, you're continuing to move forward. So anyway, I would like to see a little more transparency, but I'm hearing more transparency in the discussions now about all of the issues around this, and that we need to deal with that. Okay.
Let's take a question from the gentleman in the back row.
Thank you. My name is Matt Reeves. I'm the medical director at Women Care Global, a part of IPASS. And I wanted to start with a comment about the silos or stovepipes. And I think I agree with everything that's been said, but the one thing I haven't heard is anything about religion. And I think that's the one issue that we can't get around and needs to be recognized. And I think it was Elizabeth who mentioned in her talk about the supplies chain for religious institutions that leaves out contraceptive and other reproductive health products. So I think that's the one place, and perhaps that's particularly unique to the U.S., but it's also been exported worldwide, and we've seen that in Uganda recently and other places. So it's and perhaps I'm just blaming the U.S., it may be indigenous as well. But that's the one issue with the silos that is hard to get around and really drives, I think, a wedge between the two groups. And it's really, and from my viewpoint, created the maternal child health side separate from the reproductive health side, and whether we can get around that is a big issue. But I guess my question is about sustainability, and I guess for Melodie, I was curious about the sustainability of your efforts in northern Nigeria, and who is paying for the misoprostol. Is it the women and their husbands? It sounded like the husbands in some cases paying for it, or is it donor supported, and is this something that can continue? And this fits into the larger picture of increasing evidence that donor-supported programs really damage the supply chain in the long run, that when you provide products for free, you suppress the free market. And perhaps for Elizabeth, some thoughts on the push method of supply logistics. And is that going towards central planning? And will you just push, say, lots of Pitocin, end up with no misoprostol and piles of Pitocin? And how do you really get the push system to work in a way that you want it without having some pull? And I would argue that we've really, in a lot of ways, given up the push system as central planning and gone to a true pull system where you have women and couples buying what they want, and the key is getting the price where they can afford it and where it's appropriate. But a lot of couples will pay for appropriately priced, high-quality products that they can rely on, and allowing the free market to work gets those prices down. But when you squash it with essentially gifts, then you never develop that free market, and when the free product's gone, you have nothing. So I guess that's more of a comment, but I would be curious on how you're making your misoprostol efforts sustainable. Thanks.
Okay, so I'm going to ask Elizabeth and Melodie to give about 5 minutes, just comments on the 4 questions and comments we've just received, and then we've got about 10 minutes left, obviously mindful of the time we need to finish by 11:30. I think I'd then like just to move on to thinking about what this means longer term, next steps, and where we go from here. So Elizabeth, Melodie, comments, responses to those 4 questions?
Sure. Mine is quite brief. I don't have anything to add to the excellent sort of policy level comments that many of you have made. On the last question about the push method, just to add a little bit more detail to what's happening in Uganda, and keeping in mind that I'm not a supply chain expert, but this shift to a push system for the 2 lowest levels of facilities is also happening at the same time that facility budgets for supplies are being transferred away from facilities and to the national medical stores. So these 2 things are both happening to give more autonomy or authority to the national medical stores. The justification for that is that it will avoid delays in payments from facilities to national medical stores for the supplies, and also that there is a history of poor quantification in the orders that facilities put together, that without proper training, the quantity of supplies ordered is incorrect. However, we also heard frequently that national medical stores doesn't actually deliver the quantity of supplies that are ordered, about delays in delivery, and about concerns about projections of future use, being based often on a sort of straight flat line from historical consumption without accounting for growing demand, either from simple population growth or from demand generation programs. And certainly facilities' needs are different within districts and within regions, and I'm really not sure how the standard kit is going to account for that. But it is promising that the discussions about that kit, which when we were there hadn't been finalized, so I'm not sure if they have been, did include making supplies available at very low levels of the health system, including magnesium sulfate at Health Centers 3. So if that in fact happens, that would be a positive benefit.
All right, so on donor-supplied products versus the market. Not a small topic.
I'm going to say in 4 minutes.
So we know some answers and we don't know some answers, is the truth on that one, and the story is developing. So what we know that governments distribute either for free or for a small fee. We know that the private sector charges a fee. We know that women, couples are willing to use the private sector and pay for that in order to get the kind of care that they want. We also know that focus and coordination is needed to pull these things together, and that includes monitoring of pricing, and I'm sure you're also concerned with that in terms of MVA. We also know that there are startup costs of distribution. There are costs to train, so think of a commercial distributor or even an NGO distributor. You need to train your sales staff to be able to promote the product. You need to build awareness in the market of the product. So what we've done in some cases is to provide funding to jumpstart that distribution or jumpstart the awareness of the product, so kind of get past that initial hurdle. We also know that we need governments to be procuring it. And yeah, so those are some of the things we know. What we don't know is ultimately what works best in terms of the pricing and the price quantity kind of mix. It looks like right now the willingness to pay is on the higher side. And we certainly believe in the power of local market forces to be able to get a product's reach much greater than it would be if it's for free. There have been some donations, significant donations, that are intended to get a product into a system, get people using it so they're familiar with it, and that includes people in communities up to providers, and get governments accustomed to and comfortable with having the product in their system. So I think there's a valid argument to be made of an initial supply that kind of primes the pump in the system. But with a low-cost product with high value, there's also an argument to be made that says that over time we should be able to scale back the funding of the commodity purchase for certain markets in order to make the product more sustainable. And you have to kind of stratify the market in terms of the quintiles as far as how you're going to mix a full price product, a subsidized product, and a free product. And right now we're basically putting all the ammunition at work, right? We're trying the public sector route, which is the free or low cost. We're trying the commercial sector market, which is full price, and we're trying the NGO subsidized social marketing route, which is the middle ground. And I think that that's going to be a really good story to watch and see how that develops.
I think just to add on that piece about the public versus the private sector, I mean, many of you will be aware that we have a new government, or relatively new government, in the UK, and our ministers are very clear that they're not ideological about a public versus private versus non-state actor delivery route. What they're keen about is getting results and actually recognising that there's a basket of different routes by which we need to intervene in order to get the broadest range of commodities available to the broadest range of people. And so I think you'll start to see a bit of a shift in the way DFID operates, with less sort of ideologically around the role of the public sector, but recognising that it is a multiple actors to deliver this. So we have 7 minutes left before the clock cuts us off. Next steps, where do we go from here? We've had quite a good discussion, I think, and raising a lot of the issues that we're all familiar with. But I wanted to encourage us to move on to what happens now. Do we all go back to our day jobs tomorrow and continue doing what we're doing, or is there something that we need to be doing together, collectively? Is there a couple of key things that this community thinks we need to be focusing on over the next 6 months, 12 months? Ideas? Suggestions?
I'll just start, too, by acknowledging how the landscape, and Misoprostol in particular, has changed over the past 5 to 6 years, and really acknowledging that this is not the work of any one agency. And Deb, your comments are very kind, and I appreciate it. And we've been able to drive a lot of these initiatives forward, but it is it is the collective energy and the collective focus of all of these agencies that you hear somebody is picking up and integrating misoprostol into their system in this region of a country, or in this overall country program, or in this element of work with a government. And I love hearing those stories, and I just want to acknowledge that this is coming together in a community effort. And so integrating, in the case of misoprostol, integrating this intervention into what you're already doing on the ground is the most cost-effective way to reach the biggest number of our intended women.
Tim, please.
Again, Tim Thomas from the task force. After this meeting, PAI and the Woodrow Wilson Center have kindly volunteered to host a luncheon to begin talking about a potential an interagency working group on this issue of maternal health commodities. I'm not sure how many people we have signed up, and if there is room for others, or if our reservation list is cut off. But this working group's goal, as I understand it, and Jess, Elizabeth, Carolyn, please correct me if I'm wrong, is to really find out is to synthesize the work that people are doing on advocacy and research around maternal health commodities, making the procurement and distribution of them more available. And I think certainly the VSI model case study we heard today is going to be a great model for us to take forward in discussing that. But that would be an immediate next step. I mean, so immediate, I think it's happening in like a half an hour.
Well, I think the question is, should there be a working group? Or some other forum for cooperation, collaboration, more strongly than there has been among all of us in this room and all of our colleagues. We don't want to make the mistake of duplicating or creating a coalition or an entity that's just going to, be on paper. But is there a mechanism for more formal collaboration on maternal health supplies that could be effective? Which is kind of an open question for everybody. On supplies.
Bonnie.
I'm Bonnie Keith from PATH and also with the Reproductive Health Supplies Coalition. And from what I know of, I'm actually the co-chair of the Essential Supplies Task Force for the Post-Abortion Care Consortium. So that covers some of the maternal health supplies that we've been discussing today, particularly most of those that are on Elizabeth's list. And then within the coalition itself, we have a caucus on new and underutilized reproductive health technologies. And that caucus right now includes, we've been basically focusing on 9 products. We have technical briefs on each product, and right now we have briefs on Misoprostol and MVA. What, sorry? We don't have one on oxytocin, not for the caucus. That might be for a different thing. But so 2 of those 4 products that were discussed today are incorporated under the caucus. And the caucus is sort of the natural area within the coalition where the maternal health supplies angle would be, I think, first addressed. However, the caucus has a unique operational role within the coalition itself in that it is not a working group and is more of like a community of practice, and it's cross-cutting and it operates through the working groups of the Supplies Coalition. So if anybody's interested in talking more about that, I actually do a lot of the facilitation and coordination for the caucus, so I can talk to people about that at lunch or after the meeting today. But those 2 areas are existing working groups and task force forums where these opportunities or where there are opportunities to discuss maternal health supplies more in depth, I think. So.
Thank you. Any final thoughts or comments from anybody on the floor? Jeff, do you want to say any final words?
Excuse me. Thank you, Julia. I would agree with your assessment. It's been very lively discussion with both the details of the practicalities of the different supplies and some of the supply challenges, but as our panelists have highlighted, the challenges, that's just the beginning. Then there are a whole other set of challenges. And then I found particularly useful this silos, stovepipes discussion and finding ways to get forward, as we've heard in so many areas. In the field is where it's least a problem, back here in D.C. and in this building and other capitals are where, at the policy level, where it is more challenging. But it sounds like we have some ways forward. So thank you all very much for today's discussion.
Thank you, Jeff. I think with a minute to go before we close, I'm going to use my prerogative as moderator just to encourage all of you to have a look at the websites of the Reproductive Health Supplies Coalition and the Partnership for Maternal, Newborn and Child Health. I'll send the links through to both to Kaylin and she can circulate it round. Both of those organisations are partner-centric organisations, so they have a very small secretariat. The Supplies Coalition is housed in Brussels, and the PMNCH is housed in Geneva, but it's very small staff, just 5, 6, 10, 12 or something, respectively. The work that is done through the members. PMNCH has something like, I think, 400 members. RHSC has about 125 members, covering government, civil society, academics, research organisations, private sector, anybody with interest in those ideas. I've just had a quick look on the websites of both. PAI is a member of both. Congratulations, well done. VSI is not yet, but I would hope would be great to have them from joining both. Not, as Carolyn said, in order to anyway undermine the great work that you're doing, but as a vehicle for recognising the important work that VSI and many others in this room are doing on these very essential issues, and hopefully elevating and sharing that best practice and hoping to contribute through the work that many other of the members are doing. So I would encourage you all to go away and to sign up if you're not already. With that, I want to say thank you to everybody in the room for what's been, I found, a really useful and informative discussion. Thank you to everybody who's been observing us around the world on the web, and ask you all to join with me in thanking our two presenters, Melodie Holden from VSI and Elizabeth Madsen from PAI. Thank you both very much for your presentations.